In this lecture, we discuss about the pharmacotherapy of peptic ulcer. So, what is ulcer? What do you mean by ulcer? Ulcer means breach or break in mucosa. So, peptic ulcer means breach or break in the mucosa of stomach or duodenum. So, peptic ulcer includes gastric ulcer or duodenal ulcer. Acid peptic disorder. What do you mean? It includes peptic ulcer, gastroesophageal reflux disease, or Zollinger-Ellison syndrome, in which there is a excessive production of the gastric acid. Major causes of peptic ulcer. What are the common causes? Why in present scenario the peptic ulcer, incidence of peptic ulcer increases? It may be due to excess use of non-steroidal anti-inflammatory drugs, lifestyle changes which leads to overproduction of gastric acid, and infection of H. pylori, which is a gram-negative bacteria, and it is infection with this bacteria is very common in developing countries due to poor hygiene. Then come to why, how peptic ulcer can occur. So in our stomach, there are certain aggressive forces which damage the mucosa, and there are certain defensive forces which balance the aggressive forces and protect our stomach or gastric mucosa. Like aggressive forces are in gastric acid, means HCl, which induces damage, and activate pepsin, which causes the proteolysis or which damages the protein or mucosa. Defensive forces are bicarbonate, mucus, and prostaglandins, which protect our gastric mucosa. So when, normally there is a balance, but if aggressive forces increases or there is a overproduction of acid and pepsin, or our defensive forces decreases, means there is a decrease in mucus production of prostaglandin inhibition, all leads to gastric ulcer or peptic ulcer. So come to the physiology of the HCl secretion, how the acid secretion occurs. So there are different phases of acid secretion, but when we see the food usually, there is a stimulation of the vagus nerve. Stimulation of the vagus nerve causes the stimulation of enteric nervous system, ganglion cell, which releases the acetylcholine. Acetylcholine can directly stimulate the M3 receptor present on the parietal cell. Parietal cells are responsible for the secretion of H ions, which maintain the which are responsible for the acidic pH. So secretion of the acetylcholine by the enteric nervous system ganglion cell causes the stimulation of M3 receptor on the parietal cell, which can increases the H ion secretion through increasing the calcium. Then acetylcholine can also stimulate the histaminocytes through muscarinic receptor, which result in histamine, which can act in the parietal cell by H2 receptors, and causes the increase in cyclic AMP, and finally increases the H ion secretion through the hydrogen potassium ATPase pump. And when we take the food, again it stimulates the G cells, which can increase the gastrin, which causes the secretion of cholecystokinin, that can again stimulate the histaminocyte and increases the release of histamine, which increases the H ion, and it can directly act on the cholecystokinin receptor, which can increase the which can again increase the hydrogen potassium ATPase pump and increases the H ion concentration. So here we see the main secretagogues are mainly acetylcholine, histamine, and gastrin. Here we can see the prostaglandins, which inhibits the H ion secretion, and thus it is protective. So this is the normal physiological secretion of H ions in the canaliculum. So if peptic ulcer, if we think what are the different approaches, different approaches for the treatment of the peptic ulcer. We can reduce the gastric acid secretion by inhibiting the secretococcus action, or neutralizing the acid by using the antacids. We can use the ulcer protective, ulcer healing agent, and anti-H. pylori agent. We have seen that H. pylori is one of the important causative factor for the peptic ulcer, and so we can use anti-H. pylori drugs. So come to the drugs which reduces the gastric acid secretion. So one of the we have already seen that all the secretococcus increases the H ion secretion through the hydrogen potassium pump. So blocking this hydrogen potassium pump is a great idea. So these are the very potent drug and most effective treatment for the gastric ulcers. Proton pump inhibitors, the drugs are omeprazole, lansoprazole, pantoprazole, etc. H2 blockers, antihistaminic drug like cimetidine, ranitidine, famotidine. We have already seen the H1 blockers which are used in allergies. Here we have seen the H2 receptor blockers. Then anticholinergic drug, particularly M1 blockers, pyrangipine, tilagipine. Then prostaglandin analogs. We have seen that prostaglandin analogs are protective and decreasing the secretion. So we can use this also, like prostaglandin analogs, misoprostol. So first important drug is proton pump inhibitors, different, or we can say hydrogen potassium ATPase pump blocker. And the drugs are omeprazole, S-omeprazole, which is a S isomer of omeprazole, lansoprazole, pantoprazole, rabeprazole. These all are near about similar in efficacy. So when we are using the proton pump inhibitor, we have to keep in mind about the cost of the drug, because all are near about similar in efficacy. And in sometimes some drugs are more potent, or some drugs are longer acting. These factors also keep in mind while prescribing this PPI. Pantoprazole is more acid stable and also available as a IV preparation. Rabeprazole is most potent and long-acting PPI. Lansoprazole is very potent for H. pylori therapy. So we include this drug also while using anti-H. pylori regimes. So how proton pump inhibitor works? So these drugs are pro-drug and very acid labile. So we have to give these drug in encapsulated form. And when the drug reaches in a small intestine, it dissolves, the capsule is dissolved, and the drug is absorbed and reaches in circulation, reaches to parietal cell, canaliculi, and get activated to form sulfonic acid and sulfonamide. And this sulfonamide irreversibly or covalently bound to the hydrogen potassium ATPase pump and inhibit the secretion of gastric acid irreversibly. So there is, and one thing you must remember, that these drugs particularly block the activated phase of the pump, and the inactivated pump are not much affected, but the activated form of pump are more affected. They decreases the basic acid secretion and stimulated secretion also, but 90 to 95%. So they are very effective drugs. The plasma half-life is short, like 0.5 hour to 3 hour, but you see the duration of action is very long. Means the drug is eliminated in 0.5 to 3 hour, but their effect persists for 24 hour to 48 hours, 2 days. Administered, they must be administered 30 minutes before the breakfast, because at this time the maximum amount of pump are activated, are in form of activated. So so we can achieve maximum inhibition of pump at before breakfast. bioavailability of these agents also decreased by food. The common side effects are nausea, abdominal pain, constipation, flatulence, and diarrhea. Though the side effects are not very much common, but the common side effects are these. Rare side effects are like myopathy, arthralgia, headache. They can cause vitamin B12 deficiency because acidic pH is required for the absorption of the vitamin B12, skin rashes, and others. On chronic use, there are recent evidences or recent studies proves chronic use may result in hip fracture since it reduces the calcium absorption. We have seen, because as we have seen that they are very potent inhibitor of the acid secretion, and so there is increased susceptibility to certain infection because acidic pH protect us from various type of infection. So if we are producing achlorohydria, then definitely there is increased susceptibility of the infection like hospital-acquired infection, hospital-acquired pneumonia, community-acquired Clostridium difficile infections. There is hypergastrenemia. So drug interaction, come to though they don't have many drug interactions, but there are few, like they interfere with the elimination of warfarin, diazepam, cyclosporin due to inhibition of their metabolism. Omeprazole inhibits CYP2C19 and so decrease the clearance of phenytoin and resulting in increased level of phenytoin, which may result in adverse effect of phenytoin. Omeprazole inhibits the conversion of clopidogrel to the active form. So patient is stabilized in clopidogrel may have a failure of clopidogrel after omeprazole therapy. Uses, they can be used for peptic ulcer like gastric ulcer, duodenal ulcer, bleeding peptic ulcer, Zollinger-Ellison syndrome, and gastroesophageal reflux disorders. Then next important group is H2 blocker. We have seen histamine is important secretive box, and they are not very much effective in compared to the PPI, because if we block the histamine receptors, there are certain other way that which can stimulate the hydrogen potassium ATPase pump and can cause the acid secretion. So they are not very much effective, but they are good drugs. Like they causes the suppression of acid secretion about 60 to 70%. The drugs under this are like cimetidine, ranitidine, famotidine, roxetidine. They are competitive blocker of histamine receptor, and 24 hour acid secretion is reduced by 65 to 70%. They suppress secretion in all phases, but mainly nocturnal acid secretion is inhibited. Cimetidine is not very much used presently, but it has only historical importance because it get the Nobel Prize for the discovery, but not much use because of the anti-androgenic effect, because this drug have a anti-androgenic effect and has a many drug interactions. So not very much it is used. The other drugs of this group like ranitidine, famotidine are much used, and they are much more potent as compared to ranitidine and have less adverse effect as compared to cimetidine. So indication of histamine blockers are gastric ulcer, duodenal ulcer, stress ulcer, reflex, uncomplicated GERD. They can be used in pre-anesthetic medication and refractory urticaria. The ADR are not very common, and sometimes the patient may complain of diarrhea, headache, drowsiness, fatigue, muscular pain, constipation, and thrombocytopenia. Though I have already told that the ADR are not much common with the drugs. Then come to the anticholinergic drug. They are not very much effective, and they are only just mentioned in the list, but not very much preferred drug, because it is not the main mechanism for the secretion of acid. They exhibit weak anti-secretory effect. They can decrease basal acid secretion by 40 to 45%. There are many adverse effects of anticholinergic drugs like dryness of mouth, blurring of vision, tachycardia, urinary retention, and so non-selective anticholinergic are not preferred. And if we are going to prefer, or if we want to use anticholinergic drug, if we want to combine anticholinergic drug, we prefer M1 blocker, M1 antagonist, parangipine, tilangipine, that inhibit the transmission in parasympathomimetic enteric ganglion. Then next is prostaglandin analog, misoprostol. We have seen how the prostaglandins are protective. They are involved in inhibition of the gastric acid secretion, increase in the mucus and bicarbonate secretion, and also increase in mucosal blood flow that help in removal of H ions and replacement of damaged epithelial cell. So prostaglandin analog are used for the treatment of the peptic ulcer, and particularly NSAIDs induced peptic ulcer are I think must be the indication for that. Though again these drugs are not preferred, and for NSAID induced peptic ulcer, again the drug of choice is proton pump inhibitor. And prostaglandin analog are not much preferred because of adverse effect like abdominal cramp, diarrhea, headache, fever, potential for the abortion in case the female is pregnant. Then so we have covered the one approach, that is decreasing the acid secretion. Now other approach is neutralization of gastric acid. That is antacid, use of antacid. They are the effect of the antacids are very rapid, and they quickly neutralize the acid and relieve the symptoms. So two type of broadly we can say two type of antacids are used, like systemic and non-systemic. Systemic are sodium bicarbonate and citrate, and non-systemic is magnesium hydroxide, magnesium trisilicate, aluminum hydroxide, and calcium carbonate. Sodium bicarbonate, the sodium bicarbonate is not very much used because it is absorbed systemically, and large dose will cause alkalosis. It produces the carbon dioxide in stomach. When the sodium bicarbonate react with the HCl, the carbon dioxide is produced, which causes the distension and discomfort, belching, and there is also a risk of ulcer perforation. So sodium bicarbonate is not very much produced. They also causes the acid rebound, and increase in sodium load may worsen the edema and heart failure. As sodium increases the water absorption, so the circulatory volume increases and may precipitate the heart failure. Non-systemic antacids like aluminum compound, aluminum compounds, aluminum hydroxide are weak antacids. They inhibit the motility, so delay gastric emptying, produce constipation. It also inhibit the phosphate absorption, so increase in calcium absorption from bone. Hence, chronic use may lead to phosphate depletion syndrome, hypercalcemia, calciuria, and osteomalacia. Magnesium compound, rapidly acting strong antacid, increase GI motility and produce diarrhea. Contraindicated in renal insufficiency in view of potential risk of hypermagnesemia that may lead to neurological, neuromuscular, and cardiovascular depression. See, the non-systemic antacids are usually not absorbed, but magnesium compound may little bit absorbed, and contraindicated, strictly contraindicated in renal insufficiency, as a little bit magnesium which is absorbed may lead to neurological, neuromuscular, and cardiovascular depression. Calcium salt, rapidly acting strong antacid with longer duration of action, but It causes acid rebound. Milk, if taken with the large amount of milk, it can cause milk alkali syndrome, which may lead to drowsiness, abdominal pain, abdominal distension, weakness. Then hypercalcemia, constipation, belching, abdominal discomfort. These all can occur with the calcium salts. Then antacid combination. Why we don't prefer single antacid. We prefer the combination of antacid. Most commonly, like magnesium hydroxide and aluminum hydroxide are often combined to get us prompt as well as when we combine the magnesium hydroxide and aluminum hydroxide, magnesium hydroxide act fast, and so we get a prompt as well as sustained effect. Magnesium salts are next important point is magnesium salts are laxative, while aluminum salts are constipating. So bowel movement may be least affected. Both type of effects are nullify each other, and bowel movement is least affected. Dose of individual component is reduced, systemic toxicity is minimized, and it improves the overall patient compliance. So the combination of the salts are preferred. Then cytoprotective drugs, sucralfate, it is aluminum salt or sucrose octosulfate. It adheres with the ulcerated mucosa by forming a viscous adhesive gel in the presence of acid. When the sucralfate is taken, it form a gel-like substance in the acidic pH and adhere to the base of the ulcer and protect it from the exposure to the acid. It remain adhered to the base for 6 hours. It must be given 1 hour before the meal, or and if already food has taken, then you can give the drug after 2 or 3 hours. The problem with this drug is we have to take this drug 3 times or 4 times for adequate protection. This is a little bit problematic, and the ADR are constipation, dryness of mouth, formation of hard mass like bezoars in intestine. Sucralfate should be avoided in patients with renal failure. Sucralfate may inhibit the absorption of drugs like phenytoin, digoxin, cimetidine, ketoconazole, and fluoroquinolones antibiotics. So never take any drug near with sucralfate, along with the sucralfate. The next drug is bismuth subsalicylate. Bismuth subsalicylate increase secretion of mucus and bicarbonate through stimulation of mucosal prostaglandin production. It increases the mucosal prostaglandin production. CBC, CBS and mucus form a glycoprotein bismuth complex, which coats the ulcer and act as a diffusion barrier to the acid. So bismuth is increasing both prostaglandin production, and it forms a coat. Means it is a cytoprotective also. It forms a coat and act as a barrier. It also detaches the H. pylori from the surface of mucosa and directly kills the organism involved in the causation of the ulcer and relapses. But the problem is prolonged use has a potential to cause osteodystrophy and encephalopathy due to bismuth toxicity. Then come to anti-H. pylori drugs. We have seen that H. pylori is one of the important causative factor responsible for the ulcers, and in developing countries particularly it is more common due to poor hygiene. The H. pylori is a gram-negative bacteria, and it is able to survive in acidic environment of the stomach. How it is possible to survive in the acidic pH? It converts the urea to the ammonia with the help of enzyme urease, and ammonia is responsible for alkaline environment. So ammonia, this alkaline in alkaline environment, this bacteria can easily survive. But this is not alkaline environment is not suitable for the gastric cell, and it damages the mucosa by very high alkalinity, produce enzyme. These bacteria produce enzyme like protease, lipase, which further damage the mucosa. H. pylori infection can be detected by urea breath test. The drug used for the H. pylori infection is PPI, either omeprazole or lansoprazole. Then the antibiotics, as it is a bacteria, so antibacterial agents are also used, like clarithromycin. We can use clarithromycin, tetracycline, amoxicillin, metronidazole. So two of the given antibiotics can be combined with the PPI. So there are triple drug therapy or quadruple therapy, both for 14 days. In triple drug therapy, we use either omeprazole or lansoprazole combined with the two antibiotics from the given list. In quadruple therapy, we use PPI, then bismuth subsalicylate, and two antimicrobial from the given therapy. So therapy of H. pylori infection, triple like one PPI, clarithromycin 500 milligram, and amoxicillin 1 gram twice a day can be used. These are the famous resin which can be used for H. pylori infection. And in quadruple therapy, PPI, metronidazole 250 milligram, bismuth subsalicylate 525 milligram, plus tetracycline 500 milligram 4 times daily. So that's all about the PPI. That's all about the peptic ulcer therapy. And thank you.